Alright, so I guess we'll just start off with a little introduction. So tell us your name, a little bit about what you do, and either practicing medicine, teaching.
My name is William Chey. I'm a professor of medicine at the University of Michigan Health System. I'm the director of the GI Physiology Laboratory here and also co-director of a program that takes care of patients with functional GI disorders.
And so we're talking about gluten today, so I guess we'll just start off with the most basic question. What is gluten?
Gluten is actually a storage protein. It's a protein that's found in common grains that are a huge part of the Western diet. So wheat, barley, rye are the main grains that contain gluten. And gluten really is one of the main proteins that is contained in those grains.
So it being one of like the most main parts of wheat, would you consider it beneficial?
I'm not sure that I'd think about it as either beneficial or deleterious. It's clearly a potential protein source. It can be problematic for some individuals. So some individuals do have problems with gluten. Traditionally, there are many societies, for example, where gluten-containing grains weren't really part of the diet. So there are some populations that actually have developed problems in association with eating gluten.
So we're also going to be talking about celiac disease a little bit, so because most people don't know that the gluten-free diet was made for people with celiac disease. So just what is celiac disease?
So celiac disease is a specific genetic disorder where individuals are sensitive to ingesting foods that contain gluten. Specifically, gliadin, which is a protein, storage protein in gluten, leads to an immune reaction in the GI tract that causes inflammation. And that inflammation in the GI tract can lead to a whole host of different gastrointestinal problems as well as non-gastrointestinal problems. So traditionally we thought about celiac disease as a condition that's associated with the development of things like bloating, abdominal cramping, diarrhea, malabsorption. That inflammation leads to the inability to be able to normally absorb nutrients through the small intestine. And related to that, when celiac disease was first described, it was oftentimes associated with the development of significant malnutrition. That's not what we see nowadays. It's interesting that celiac disease has evolved for reasons that are not entirely clear to get away from frank malnutrition with massive diarrhea, weight loss, nutrient, vitamin, mineral deficiencies, mostly seen in kids, to now being a condition that mostly manifests as vague GI and non-GI related symptoms without evidence of necessarily of malnutrition, oftentimes diagnosed in adults.
So, okay then, we have celiac disease, and then we're seeing more now, people are saying that I'm sensitive to gluten, and then we're calling these people non-celiac gluten sensitivity, I guess, would be the most appropriate medical diagnosis to give them. So what is non-celiac gluten sensitivity?
Yeah, so it's really important to make the distinction between celiac disease, which is that well-defined genetic disorder associated with intestinal inflammation as a byproduct of ingesting gluten, compared to individuals that develop symptoms when they eat wheat or other grains that contain gluten that don't have celiac disease. These are individuals that we refer to as suffering from non-celiac gluten sensitivity. Now, non-celiac gluten sensitivity, the name implies that the symptoms are always as a consequence of gluten. But it turns out that that's probably not the case. It turns out that non-celiac gluten sensitivity is probably a heterogeneous group of conditions where an individual will develop either GI symptoms or non-GI symptoms. Just to give you some examples. The GI symptoms that are most common are things like diarrhea, bloating, flatulence, abdominal cramping. But also non-GI symptoms are really common. So things like fatigue, skin rashes, joint pains, a whole variety of different vague non-GI symptoms have also been associated with eating foods that contain gluten. And what I was getting at earlier was that the name implies that the problems are always related to gluten. And what we're finding over time is that while some patients develop problems in association with eating gluten, sometimes the symptoms have nothing to do with gluten and are related to other aspects, either psychological or physiologic aspects of eating foods containing wheat.
All right, cool. So, you read the Huffington Post article, right? Or looked at it at least. So, the doctor in the article, Mark Hyman, he says that eating gluten can lead to the development of multiple diseases. I think he listed about 50 of them. Some of them being IBS, cancer, rheumatoid arthritis, lupus, MS, schizophrenia, dementia, migraines, autism. So, what's the, I guess what I'm just asking is, can they?
Yeah, so celiac disease can lead to a whole variety of different types of manifestations. Okay, and some of those manifestations can be GI related. So, for example, it's not uncommon for patients with celiac disease to describe symptoms that would be compatible with the diagnosis of irritable bowel syndrome, or IBS. So that would be the presence of abdominal pain or discomfort, bloating, as well as altered bowel habits. Those symptoms are common in patients with celiac disease, so they can overlap. Those conditions can overlap. But it's not that celiac disease causes IBS. It's celiac disease and IBS can have similar symptoms, which can be confused. And that the same could also be said for a lot of these other things that are associated with celiac disease. Really interesting that celiac disease, everybody I think knows about the GI problems that can occur with celiac disease, but many people don't realize that celiac disease is actually an important cause of unexplained iron deficiency anemia. Also, premature osteoporosis, that demineralization of bone that can lead to fractures, development of fractures. Also, a very important association with celiac disease. And you can imagine how malabsorption of iron and calcium and other types of nutrients could be associated with development of those types of conditions. Another thing that's interesting about celiac disease, so many things are interesting about celiac disease, but one aspect that gets overlooked is mental illness. So people have talked about, for example, depression, a variety of other types of psychological abnormalities that are associated with celiac disease. So people really do need to think broadly when considering celiac disease and the differential diagnosis of medical conditions. Another thing that many people don't realize that's an important thing to know about is infertility. Celiac disease is also associated with a higher rate of infertility, and so it's very common now for obstetricians to be, or fertility specialists to be testing for celiac disease now in women who have trouble getting pregnant.
Interesting. I didn't know that. Cool. So, around 99, or Mark Hyman says around 99% of those with celiac disease they have the diagnosis, but they don't know it. And so is this undiagnosis of the 99% of people who have celiac disease, is it a really serious problem, and is it costing the healthcare system money?
It is true that the vast majority of individuals with celiac disease in the United States, and indeed many parts of the world, have not been diagnosed. Okay, now, if you think about that statement, it makes it sound like there's a huge number, that this is an incredibly common problem. And while it's more common than we initially thought, just to give you some numbers, when I was in medical school 25 years ago, I was taught that celiac disease occurred in around 1 in 500 individuals. Okay, so really rare, right? More recent prevalence data from the United States suggests that the prevalence is probably somewhere between 0.5 to 1%. So somewhere between 1 in 100 to 1 in 150 to 200. So it's much more common than we initially thought 20 years ago. And indeed, something that's talked about in that Huffington Post article, that's true based upon literature. In fact, literature that we published in the American Journal of Gastroenterology, for which I'm the editor, one of the editors, co-editor. There's data that persuasively suggests that the prevalence of celiac disease seems to be increasing over time. So it seems to be becoming more common. All sorts of interesting hypotheses around that that might be worth discussion. But the key thing to remember is that while it's more common than we thought, it's not like everybody has celiac disease. So think about that. So 0.5 to 1%. It's more common than we thought, but it's still not that common. Okay, the incredible thing to think about is that if you believe that the prevalence is around 1%, that's still millions of people in the United States, and the vast majority of those people are undiagnosed. But it's not like this is an epidemic sweeping the country.
Okay. We're recording. Okay. So, back to where we left off. All right. So, how does gluten affect an individual with celiac disease compared to an individual without celiac disease?
So in patients with celiac disease, the ingestion of gluten leads to a clear inflammatory response in the small intestine. So that protein stimulates the immune system abnormally and causes an intense inflammatory response in the small intestine that leads to a whole cascade of events that can cause symptoms, malabsorption, all the different things that celiac disease is associated with. On the other hand, non-celiac gluten sensitivity is not nearly as well defined. So the condition clearly is associated with development of symptoms, both GI and non-GI symptoms, but the mechanism by which those symptoms are caused is not nearly as well defined or as clear as for celiac disease. It may have to do with a subtle type of immune reaction, almost something like a variant of food allergy. That's possible. It's also possible that certain carbohydrates in wheat, for example, are associated with development of symptoms in certain individuals. And then the last thing is this whole idea of the nocebo response, this idea that there's so much negative information about gluten out there in the press these days that people are almost preconditioned to think that foods containing gluten are going to be bad for them. Mm-hmm. And so when they eat them, the foods will make them feel bad.
All right. Cool. And then, so it's estimated right now that 30% of the people would either like to be on a gluten-free diet or thinking about going on a gluten-free diet. So if these people without celiac disease are going to go on this diet, what would be the possible pros and cons that they would face while on the diet?
You know, it's funny, as doctors, we talk about this whole gluten craze quite a bit because some people believe that it's a real phenomenon. Some people believe that it's quite overblown, and probably the truth is somewhere in between. What's very clear, though, is that regardless of how physicians feel about it, patients are voting with their feet. You know, this is a multi-billion-dollar industry worldwide at this point. If I always say this when I lecture about this, if a gluten-free diet was a pharmaceutical drug, it would be considered a blockbuster. You know, blockbuster drugs are those that sell more than $1 billion worth of products. The gluten-free diet is well past that point already. So the horse has left the barn in terms of how patients feel, how the lay public feels about this. Are there potential benefits? Yeah, for some individuals there are absolutely potential benefits, certainly in terms of symptoms. Whether or not it has any impact on cancer risk or longevity, I doubt it, to be honest with you. But in terms of helping with GI symptoms, maybe even in some cases non-GI symptoms, absolutely. One example is my brother is actually a performance athlete. He does Ironman races. And he's gone gluten-free, and interestingly, he tells me that his performance has improved, and that he feels better overall, since going gluten-free. You hear many stories like this as a healthcare professional. So I think where there's smoke, there's fire, and there's definitely something to this, although the precise mechanisms and the exact benefits vary tremendously from person to person.
Cool. So then would you recommend a gluten-free diet to someone that is not diagnosed with celiac disease?
Yeah. So for an individual with vague GI symptoms that they think are associated with the ingestion of grains that contain gluten, a gluten-free diet would be a reasonable way to go. Similarly, and more, I do this more in my own practice, I don't put them on a gluten-free diet, I put them on a low FODMAP diet. So FODMAP is an acronym that refers to fermentable oligo, di, monosaccharides, and polyols, which are basically short-chain, poorly absorbed carbohydrates that, because they're not absorbed in the intestine, get down to the colon where they're fermented by bacteria. Now, it turns out that normal individuals can eat FODMAPs until the cows come home and they get no problems. But individuals with underlying GI problems, for example, irritable bowel syndrome is probably the best characterized example. If IBS patients eat a lot of FODMAPs, they will almost invariably get significant symptoms: cramping, bloating, flatulence, diarrhea, even constipation for some selected patients.
Okay, so the study by Jessica Biskarski, I don't know how to pronounce her last name.
Right.
But so she recently published that study in 2013 that pointed towards FODMAPs causing the main factor of non-celiac gluten sensitivity as opposed to gluten. So what do you think about the study's results?
Yeah, I think the literature pertaining to the issue of non-celiac gluten sensitivity is in evolution, and it's confusing. Okay, so there was a study that we published in our journal, the American Journal of Gastroenterology, a couple of years ago now, suggesting that a gluten-free diet was associated with a reduction in symptoms in IBS patients. There's been a subsequent article, more of a translational study published by the Mayo Clinic group, that found that the ingestion of gluten was associated with immune activation as well as altered permeability or leakiness of the gut in individuals with IBS. And then there's most recently literature being published out of Monash University. Peter Gibson is the senior author. His group, which has really led the charge in terms of the whole low FODMAP phenomenon, in conjunction with a dietitian named Sue Shepard, who's no longer at Monash. And what their group has found is that the benefits of a gluten-free diet may largely be attributable to FODMAP exclusion. Now, how does that work? Well, realize that wheat, in addition to being a very fertile source of gluten, is also the largest source in the Western diet of fructans. Fructans are basically long chains of fructose molecules that are linked together and can't be digested or absorbed in the human small intestine. So because of that, they always get to the colon and they get fermented in the colon by bacteria. So these fructans can cause problems. If you eat too much fructans, it can cause problems for some individuals, like IBS patients, for example. And it's been argued that it's not so much the gluten in wheat that causes the symptoms as it is the fructans in wheat that causes the symptoms. And my own personal opinion is it's both. Some individuals are probably sensitive to gluten. On the other hand, many of the individuals that get symptoms in response to eating wheat are probably reacting to the fructans.
Mm-hmm. So you've talked about IBS a lot and then how there's a lot of overlap of symptoms. So do you think it's important for individuals to get tested to see, which one they have, and then based off that, which diet they should pursue or which medications they should have?
It's critically important that people in the general population understand that if they're concerned about gluten causing their symptoms, it's fine to go ahead and try a gluten-free diet, but here's the problem. If you go on a gluten-free diet and then you go to see a healthcare provider and you want to get tested for celiac disease, unfortunately, going on a gluten-free diet will have a tendency to cause false negative blood testing for celiac disease. In other words, it'll cause a positive test to turn negative by removing gluten from the diet. So it's important, if you're at all concerned about celiac disease, to get tested before you go on a gluten-free diet, because once you go on a gluten-free diet, it confounds the ability of a healthcare provider to make an accurate diagnosis of celiac disease.
Cool. And I guess we'll stop it again. I guess I'll ask, so what are you and other gastroenterologists currently researching or studying about gluten or FODMAPs in general right now?
Almost all the literature on the low FODMAP diet has come from outside the United States. In fact, all the literature has come from outside the United States. It's interesting that the low FODMAP diet is starting to really gain some traction in the United States, but based on no literature from the United States. The vast majority of the literature has come from Australia, so from Monash University, Peter Gibson's group, also from King's College in the United Kingdom. We've just recently seen some literature from Italy, and we're starting to see some literature trickling in from other parts of the world. So, for example, like Belgium. We're doing a number of studies here at University of Michigan to evaluate the low FODMAP diet. We're doing a randomized controlled trial evaluating the low FODMAP diet in patients with irritable bowel syndrome. We're hoping to publish the first U.S. data from a methodologically rigorous, adequately powered study that shows the benefits or not of the low FODMAP diet. We'll have to see how that turns out. We're also just starting a randomized controlled trial, another study, looking at the potential benefits of low FODMAP diet in patients with fecal incontinence. So we're quite actively investigating the benefits of this diet at the University of Michigan. We're not only looking at the clinical benefits, we're also looking at a variety of what we call biomarkers, so effects on inflammatory markers, effects on the microbiome, effects on permeability or leakiness of the GI tract. So hopefully at the end of these studies, we'll be able to provide important information in regards to not only whether the diet works, but how it works. One question that comes up a lot is whether or not lay persons should just do this on their own. And the problem is that a lot of the information that's available comes from the internet. And while some sources are quite reputable and comprehensive, many sources are not. And so I think it's important for individuals that are looking to embark on this journey of thinking about comprehensive dietary intervention for GI symptoms, to seek the advice of a healthcare provider, and in the optimal situation, actually see a dietitian. Because a dietitian will help the patient to gather information using diaries to sort of comprehensively look at associations between certain foods and the individual's symptoms, and then give them medically and nutritionally responsible advice on how to administer a gluten-free diet or a low FODMAP diet. One thing too to realize about low FODMAP, most people don't realize this, is they focus on the exclusion part, that is removing all the foods that contain FODMAPs. An important thing to realize about the low FODMAP diet is that a critical part of the diet for responders, let's say that you go on the low FODMAP diet for a period of 4 to 6 weeks and you get dramatic improvement of your symptoms. Well, what a dietitian will help you to do then is to selectively reintroduce groups of FODMAP containing foods to come up with your individual low FODMAP diet. So 6 months out, 4 to 6 months out, almost nobody's on that full FODMAP restriction anymore. They're on a modification of the diet, and that only happens, or I shouldn't say only, but it happens optimally with the help of a dietitian.
So you recommend seeing a dietitian?
I do.
All right.
Okay?